Continuing with chapter 34, anaphylaxis. Anaphylaxis is also called anaphylactic shock. It's a life-threatening allergic reaction that involves generalized multi-system response to an antigen characterized by airway swelling and dilation of blood vessels. Common causes are insect stings, medications, or food. Signs and symptoms of anaphylactic shock in the pediatric patient include hypoperfusion, stridor and/or wheezing, increased work of breathing, altered appearance, restlessness, agitation, and sometimes a sense of impending doom. Hives are usually present. Treatment of pediatric patient with anaphylactic shock: maintain the airway and administer oxygen via the tolerated route. In stable patients, allow the parent or caregiver to assist in the positioning of the patient, oxygen delivery, and keeping the patient calm. Based on protocol, assist with the epinephrine auto-injector if available. Pediatric epinephrine auto-injector supplies in a dose of 0.15 milligrams and is given intramuscularly into the lateral thigh, provide rapid transport. Bleeding disorders. Hemophilia is a congenital condition in which the patient lacks one or more of the normal clotting factors of blood. Most forms are hereditary and are severe, predominantly found in the male population. Bleeding may occur spontaneously. All injuries become serious because blood does not clot. Transport immediately. Do not delay to apply a tourniquet for life-threatening hemorrhage. Neurologic emergencies and management. Altered mental status. Altered mental status is an abnormal neurologic state in which the pediatric patient is less alert and interactive than is age appropriate. Understanding normal developmental or age-related changes in behavior and listening carefully to the caregiver's opinion are key. A pediatric patient not behaving in a developmentally appropriate manner could indicate an altered mental status. The mnemonic AEIOU TIPS reflects the major causes of altered mental status and is shown there on the screen for you. Signs and symptoms vary from simple confusion to coma. Management focuses on the ABC and transport. If level of consciousness is low, the pediatric patient may not be able to protect his or her airway. Ensure a patent airway and adequate breathing through a non-rebreathing mask or a BVM and transport to the hospital. Seizures is the result of disorganized electrical activity in the brain. Common causes of seizures are child abuse, electrolyte imbalance, fever, hypoglycemia, infection, ingestion, lack of oxygen, medications, poisoning, seizure disorder, recreational drug use, head trauma, or there can be seizures for no common cause that can be found. They may manifest in a variety of ways depending on the age of the child. Seizures in infants can be very subtle, consisting of only an abnormal gaze, sucking motion, or bicycling motions. In older children, seizures are more obvious and typically consist of repetitive muscle contractions and unresponsiveness. Once the seizure stops, the patient's muscles relax, becoming almost flaccid or floppy, and the breath becomes labored. This is called the post state. The longer and more intense seizures are, the longer it will take for this imbalance to correct itself. Once the pediatric patient regains normal level of consciousness, the post-ictal state is over. Seizures that continue every few minutes without regaining consciousness in between or last longer than 30 minutes are referred to as status epilepticus. Recurring or prolonged seizures should be considered potentially life-threatening. If the patient does not regain consciousness or continues to seize, protect the patient from harming himself or herself and call for ALS backup. These patients need advanced airway management and medication to stop seizures. Here are those common causes of seizures that we just explained. Management. Securing and protecting the airway are your priorities. Position the head to open the airway. Clear the mouth with suction. Consider placing the pediatric patient in the recovery position if he or she is vomiting and suction is inadequate. Provide 100% oxygen via non-rebreathing mask or by blow-by method. Begin BVM ventilations if there are no signs of improvement. Some caregivers will have given the child a rectal dose of diazepam prior to your arrival. Monitor breathing and level of consciousness carefully and transport to an appropriate facility. Meningitis is an inflammation of tissues or the meninges that cover the spinal cord and brain, caused by an infection by bacteria, viruses, fungi, or parasites. If left untreated, can lead to brain damage or death. Being able to recognize in pediatric patients with meningitis is an important skill to have. Some individuals at greater risk are males, newborn infants, children with compromised immune systems from AIDS or cancer, children who've had any history of brain, spinal cord, or back surgery, children who have head trauma, children with shunts, pins, or other foreign bodies within their brain or spinal cord, especially children with VP shunts. Signs and symptoms of meningitis vary depending on the age of the patient. Fever and altered level of consciousness are common symptoms in all ages. Changes in the level of consciousness can range from mild to a severe headache to confusion, with lethargy or the ability to understand commands or interact appropriately. Children may also experience a seizure, which may be the first sign of meningitis. Infants younger than 2 to 3 months can have apnea, cyanosis, fever, and a distinct high-pitched cry or hypothermia. Meningeal irritation or meningeal signs are terms used to doctors to describe the pain that accompanies the movement and often results in the characteristic stiff neck. One of the signs of meningitis in an infant is increasing irritability and a bulging fontanelle without crying. Neisseria meningitidis is the bacterium that causes the rapid onset of meningitis symptoms and often leads to shock and death. Children with meningitis typically have small pinpoint cherry red spots or a larger purple and black rash on the face or body. These children are at serious risk of sepsis, shock, and death. All pediatric patients with suspected meningitis should be considered contagious. Follow standard precautions when dealing with pediatric patients with possible meningitis and follow up to learn the patient's diagnosis. If exposed to saliva or respiratory secretions, you should receive antibiotics. Treatment of a child with suspected meningitis: provide supplemental oxygen and assist with ventilations if needed. Reassess vital signs frequently during transport to the highest level of service available. And it's talking about that rash. Gastrointestinal emergencies and management. Never take a complaint of abdominal pain lightly because a large amount of bleeding may occur within the abdominal cavity without any outward signs of shock. Monitor for signs and symptoms of shock, including an altered mental status, pale, cool skin, tachypnea, tachycardia, or bradycardia. Complaints of a gastrointestinal origin are common in pediatric patients, maybe from ingestion of certain foods or unknown substances. In most cases, the pediatric patient will experience abdominal discomfort with nausea and vomiting or diarrhea. Nausea and vomiting and diarrhea can cause dehydration. Appendicitis is also common. If untreated, can lead to peritonitis or shock. Peritonitis is an inflammation of the peritoneum, which lines the abdominal cavity. Will typically present with a fever and pain on palpation of the right lower abdomen. Rebound tenderness is a common sign associated with appendicitis. If you suspect appendicitis, promptly transport to the hospital for further evaluation. Obtain a thorough history from the primary caregiver. In particular, ask questions such as how many wet diapers has the child had today? Is your child tolerating liquids, and is he or she able to keep them down? How many times has your child had diarrhea and for how long? And when he or she cries, are tears present? Poisoning is common among children, can occur by ingesting, inhaling, injecting, or absorbing a toxic substance. Common sources of poisoning in children are alcohol, aspirin, and acetaminophen, cosmetics, household cleaning products such as bleach and furniture polish, houseplants, iron, prescription medications, illicit or street drugs, and vitamins. Signs and symptoms of poisoning vary widely depending on the substance and the age and the weight of the child. The patient may appear normal at first, but then may be confused, sleepy, or unconscious. Some substances only take one pill to be lethal to a small child. Be alert for signs of abuse. After you've completed your primary assessment, ask the parent or caregiver the following questions. What is the substance involved? Approximately how much of the substance was ingested or involved in the exposure? What time did the incident occur? Are there any changes in behavior or level of consciousness? Was there any choking or coughing after the exposure? Contact poison control for assistance in identifying poisons. Treatment of a poisoned pediatric patient. First, perform an external decontamination. Remove tablets or fragments from the patient's mouth. Wipe or brush the poison from the skin. Assess and maintain ABCs and monitor breathing. Provide oxygen. Perform ventilations if necessary. If the child demonstrates signs of shock, position supine, keep the child warm, and transport promptly. In some cases, give activated charcoal according to the medical control or local protocol. Not indicated for pediatric patients who have ingested an acid, an alkali, or a petroleum product. Not recommended for pediatric patients who have a decreased level of consciousness and cannot protect their own airway or who are unable to swallow. Some common training names for suspension are Instachar, Actidose, and Liquichar. The usual dose for a child is 1 gram of activated charcoal per kilogram of body weight. Pediatric dose is anywhere from 12.5 to 25 grams. Dehydration emergency and management. Dehydration occurs when Fluid losses are greater than fluid intake. Vomiting and diarrhea are the most common causes of dehydration. If left untreated, dehydration can lead to shock and death. Infants and children are at greater risk than adults for dehydration because their fluid reserves are smaller than those in adults. Life-threatening dehydration can overcome an infant in a matter of hours. Dehydration can be mild, moderate, or severe. Signs of mild dehydration: dry lips and gums, decreased saliva, and fewer wet diapers. Signs of moderate dehydration are sunken eyes, sleepiness, irritability, loose skin, or sunken fontanelles. Signs of severe dehydration is mottled, cool, clammy skin, delayed capillary response time, and increased respirations. Treating dehydration of the pediatric patient: assess ABCs, obtain baseline vital signs. If dehydration is severe, ALS backup may be necessary for IV access. Transport to the ED if signs are moderate to severe. Fever emergencies. Simply defined, a fever is an increase in body temperature, usually in response to an infection. Temperatures of 100.4 or higher are considered abnormal. Fever is rarely life-threatening, but fever with a rash can be a sign of a serious condition such as meningitis. Common causes of pediatric fever include infection, status epilepticus, cancer, drug ingestion of aspirin, arthritis, systemic lupus erythematosus, ras across the nose will be present in that one. High environmental temperature. Fever is the result of an internal body mechanism in which heat generation is increased and the heat loss is decreased. An accurate body temperature is an important vital sign for pediatric patients. A rectal temperature is the most accurate in infants to toddlers. Older children will be able to follow directions for placing a thermometer under the tongue or arm. Depending on the source of infection, a pediatric patient may present with signs of respiratory distress, shock, a stiff neck, a rash, skin that is hot to the touch, flushed cheeks, seizures, and in infants, bulging fontanelles. Assess the patient for other signs and symptoms such as nausea, vomiting, diarrhea, decreased feedings, and headache. Provide rapid transport and manage the patient's ABCs. Follow standard precautions if you suspect the patient may have a communicable disease. Febrile seizures. Febrile seizures are common in children between the ages of 6 months and 6 years. Most pediatric seizures are the results of fever alone, which is why they're called febrile seizures. Typically occur on the first day of a febrile illness, characterized by generalized tonic-clonic seizure activity, lasts fewer than 15 minutes with little or no postictal state, may be a sign of a more serious problem such as meningitis. Assess ABCs, providing cooling measures with tepid water, and provide prompt transport. All patients with febrile seizures need to be seen in the hospital setting. Drowning emergencies and management. In a drowning emergency, you may always take the first steps to ensure your own safety. Drowning is the second most common cause of unintentional death among children aged 1 to 4 years in the United States. Children often fall into swimming pools and lakes, but many drown in bathtubs and even puddles or buckets of water. Older adolescents drown when swimming or boating. Alcohol is frequently a factor. Principal condition that results from drowning is lack of oxygen. Even a few minutes without oxygen affects the heart, lungs, and brain. Causes life-threatening problems such as cardiac arrest, respiratory failure, and coma. Submersion in icy water can lead to hypothermia. Most people in this situation die. Diving into water increases the risk of neck and spinal cord injuries. Signs and symptoms will vary based on the type and length of submersion. The pediatric patient may also present with coughing, choking, airway obstruction, difficulty breathing, altered mental status, seizure activity, unresponsiveness, fast, slow, or no pulse, pale, cyanotic skin, and abdominal distension. Management of drowning emergencies: assess and manage ABCs, contact ALS crew to intervene if needed. Administer 100% oxygen via non-rebreathing mask or BVM if assisted ventilations are required. Be prepared to suction as these patients often vomit. If trauma is suspected, apply a cervical collar and place the patient on a long board. Pad all open spaces under the pediatric patients before securing the patient onto the board. Perform CPR on an unresponsive patient and cardiopulmonary arrest. We'll go ahead and stop here.